Working with kids and their families, it's got to be one of the most rewarding parts of medicine, right? But let's be real, it can also be one of the toughest. So, in this explainer, we're going to dive into how you can flip that challenge into real confidence. So, does that idea of a consultation with a tiny crying patient and their super worried parents, does that make you a little nervous? If it does, you're not alone. It's a totally normal feeling, especially early on. I mean, you're trying to diagnose someone who can't tell you what's wrong, who's probably scared, and who, let's be clear, is not just a little adult. Well, the great news is you're definitely not alone in feeling that way. And look, this is a skill. It's just like any other skill you learn in medicine. Once you get the right framework down and you have a couple of key tricks up your sleeve, these consults can become not just effective, but genuinely rewarding and, hey, sometimes even a little bit fun. Okay, so what is it that makes these consultations so different? Well, here's the bottom line. You can't just take your adult approach and shrink it down. It doesn't work that way. You need a totally different mindset, a whole new tool set. Just look at the difference here. An adult, they can usually tell you, hey, the pain is right here. But a kid, they might just be crying and totally miserable. An adult is usually pretty cooperative, right? A child might be terrified of, well, everything. And the age range is just massive. You can't talk to a newborn the same way you talk to a teen. And here's the big one. It's family-focused. You're not just dealing with one patient, you're dealing with the whole family unit. So how in the world do you manage all that complexity? Well, you start with a rock-solid foundation. And, like any good consult, that starts with taking a structured history. But, and this is a big but, it's got to have a few really important pediatric-specific additions. And to make sure we never forget those key additions, we've got this awesome tool. It's called the Blinds Mnemonic. Seriously, this little thing will help you nail a thorough, relevant pediatric history every single time. It's easy to remember and super effective. All right, let's break this down. We're going to go through each letter of BLINS, one by one, so you can see exactly what you need to ask, and more importantly, why it matters so much. So, here's our game plan. B is for birth history. You'd be surprised how much stuff from around the birth can have effects down the line. L is for looking for neonatal sepsis risks. We'll get into that in a sec. I is for immunizations, an easy check to see what they're protected against. N, nutrition, a huge clue to their overall health. D is for developmental history, making sure they're hitting those big milestones. And finally, S is for screening for mental health, which is becoming more and more important. You can see how each letter adds another crucial piece to the puzzle. Let's zoom in on L, looking for those neonatal sepsis risks. This is one of those high-stakes areas where a great history can literally be a lifesaver. When you've got a newborn, you have to be asking about these specific things. And notice how there's a difference between a red flag, like, say, a confirmed infection in a twin, which is an all-hands-on-deck situation, and other really important risk factors, like if mom had a fever. Asking these specific questions is how you catch at-risk babies early. Okay, now for D, developmental history. And look, you don't have to be a developmental pediatrician here, but just knowing a few of the big milestones is incredibly helpful. This little timeline is a great cheat sheet. Is the baby giving you that social smile around 6 weeks, sitting up on their own at 6 months? You're just looking to see if they're generally on track. It gives you a really quick snapshot of how their brain and body are developing. All right, so you've taken an amazing history using your BLINDS framework. What's next? The examination, of course. But in pediatrics, this is less about a rigid checklist and way more of an art form. It's all about building that rapport and trust. And here is the absolute golden rule. Before you even think about putting a stethoscope on them, just watch. Seriously, watch them. Are they playing happily? Do they seem cranky or irritable? Are they moving all their arms and legs? Can you see any signs that they're working hard to breathe? Just observing the kid while you're chatting with the parents can sometimes give you more information than the entire hands-on exam. Okay, tip number 1, and it's a super practical one. Get down on their level. Think about it. Towering over a little kid is just plain intimidating. But if you kneel down or even sit on the floor, you instantly enter their world. You go from being this scary giant to a friendly, approachable person. It's such a small change, but it makes a massive difference. Next up in your toolkit, the icebreaker. Please don't just jump straight into the medical questions. Take a second, say something about the awesome dinosaur in their t-shirt, or ask what their teddy bear's name is. It gives them a chance to talk about something they actually like. And, it shows them you see them, not just a patient. And this is so important.
One size does not fit all. For a toddler, yeah, you can pretend your stethoscope is a telephone. It's fun. But for a teenager, no way. You have to respect their privacy and their dignity. That means always explaining what you're about to do, getting there okay, and making sure a chaperone is there if needed. You have to adapt. So, we've talked history, we've talked examination, but there's a third piece to this puzzle, and it is absolutely crucial, and that's the family. A lot of the time, they're kind of the hidden patient in the room, right? They've got all their own fears and worries.
And trying to navigate that family dynamic, well, it can be tricky. So let's talk about the common traps. What are the pitfalls we can fall into when we're interacting with parents and relatives? Okay, let's look at 3 big ones. First pitfall, relying only on the parent for information. Even a little toddler can usually point to what hurts, so always try to bring the child into the conversation. Second, never, ever ignore a relative's concern. Why? Because they know their child better than anyone. And third, just be aware of a potential parental agenda. Sometimes they've done their own research and come in convinced they know what's wrong. Your job is to listen respectfully, but keep an open mind and trust your own clinical judgment. But if there's one thing you take away about this, let it be this. Parents know their child best. When a parent tells you they're just not themselves, listen, that is a huge piece of clinical data. Those little subtle changes that only they would notice, they can be the very first sign of something serious. So always, always take what they say seriously. Okay, so let's wrap this all up. We've kind of gone on a journey here, right? From that feeling of being a bit intimidated to having a real structured sense of confidence. You've totally got the tools you need to do this well.
So here it is, your pediatric toolkit all boiled down. Number 1, a structured history using blinds. Number 2, an observation-first approach to the exam. 3, those simple but powerful rapport-building techniques. And 4, the mindset that parents are your partners in this. I'm telling you, these 4 things together will completely transform how you approach these consultations.
So I'll leave you with this final thought. Now that you have this framework, how are you going to use it to do more than just make a diagnosis? How will you use these skills to really connect with your next pediatric patient and their family? And, make what can be a really scary experience just a little bit better for everyone.